topic for the day is probably very apt. I think marathon seems to be going on outside. We are talking about walking difficulties elderly. If you look at my title, probably I try to look at this topic from a general practitioner's point of view or a physician's point of view, and also because basically we are physicians, from the rheumatologist point of view would include a physician's point of view as well. My job has been made very easy because the concept of gait, abnormalities of orthopedic and musculoskeletal gait abnormalities have been discussed in detail by Dr. Sharad Rao, and Dr. Srinivas had given you an excellent overview about balance, problem with the balance. Initially, I will talk about few rheumatic diseases. I am a rheumatologist, I should talk rheumatology. And what are the problems with gait in patients with rheumatoid arthritis? Rheumatoid arthritis is the most common disease which we deal with walking difficulties. The walking difficulty in rheumatoid arthritis is always multifactorial, never a single cause. And because it is by definition a polyarthritis, the problem with the feet and problem with the knee are the most common cause for somebody to have walking difficulty when they have rheumatoid arthritis, and rarely somebody can have a severe hip arthritis, which is the prime reason for them to find it difficult to walk. Imagine walking with this feet and walking with this knee. It will be extremely difficult. In addition to this, because of chronic nature of the disease, they can have a significant muscle weakness, which can again contribute to difficulty in walking, make them more prone for falling down. And in addition to lower limb abnormalities, they also have significant upper limb arthritis and difficulties that prevent them from swinging their arms in an adequate way, so that the balancing when they walk would be a little more difficult. Add to that, some of them might have a peripheral neuritis component, which can decrease the proprioceptive angle and can predispose these people to fall and have difficulty in walking. And most of the women with rheumatoid arthritis are osteoporotic as well. So when they find it difficult to walk and they fall down, most of them develop osteoporotic fractures. And pain, of course, is an important reason for them to find it difficult to walk. I'm not going to touch this. Osteoarthritis pictures have been very elegantly shown by Dr. Sharad Rao. Find the patients with this kind of knees would find it extremely difficult to walk, and probably the solution is the correct surgery at the correct time of the disease. Ankylosing spondylitis is one more disease where there may be a significant difficulty in walking, mainly because of this posture. Because when somebody has this kind of focus spine, they would find it extremely difficult to even see more than 5 to 6 feet in front of them. So walking on a road, they might be able to manage in their own room, but when they get out of the house, they are very, very, very unconfident or not confident to move around because they cannot really see what's looking ahead. And leg flexion, along with this, hip arthritis again that increases the stoop posture, and many of them also have significant Achilles tendinitis and plantar fasciitis. All of them in combination would make walking an extremely difficult task. How are we going to manage these patients' difficulties? Promptly treating rheumatoid arthritis in an early stage, preventing a knee synovitis, controlling the knee synovitis, and treating them adequately at an early stage before this happens would prevent many of the walking difficulties which could occur. And this patient has had a surgery, which is really a Herculean surgery or a very dramatic surgery. It's a very difficult surgery, I believe. Most of the neurosurgery centers don't do it. They can make the spine look better so that they can walk better. And hip replacement, of course, is an extremely efficient tool to improve the gait of many patients with ankylosing spondylitis. One more disease which we see where patients have a lot of difficulty in walking and tend to fall very frequently is dermatomyositis. You can see a nice dermatomyositis rash and a calcification. These patients find it extremely difficult to walk, particularly climbing up the stairs. And patients with osteoporosis, they don't have difficulty in walking until they have a fracture. So this contributes to the problem of difficulty in walking, which results in a fall. And when the patients have osteoporosis, they develop a significant fracture either in their hip or spine, which would make their walking difficult after that. So look and correct for vitamin D deficiency in most of the patients with elderly and correct them. And patients with osteoporosis should be treated with bisphosphonates. And nursing home patients are very elderly, frail patients could be provided with the hip protectors, which most of the aspects of walking difficulty and balance difficulty have been dealt with. I thought I will dwell a little more about the consequence of falling, difficulty in walking, that is a fall. These are all the important causes for fall. Neurological disorders have been discussed, musculoskeletal disorders already discussed, sensory abnormalities partially discussed, visual, auditory and peripheral neuropathy contribute to difficulty in walking and also increase in tendency to fall. Cardiovascular diseases like carotid sinus sensitivity, arrhythmias can make them fall. Chronic medical conditions as stressed by Dr. Srinivas. Medications, polypharmacy. Patients who take more than 4 drugs due to any disease, inert be drugs, antidepressant, inert be sedatives. Any patients, elderly patients taking more than 4 drugs are more prone to fall down. This is well studied. So the fall is a natural consequence of difficulty in walking. It is very common. In elderly population, that is above 65 years, community dwelling elderly population have a 30 to 60% of them fall every year. And the fall rate is 0.7 per year. At most, they at least fall twice in 2 years. The guy who falls more than 3 times a month is called a frequent faller. So these patients need to be identified very quickly, and we have to remedy the correctable causes. And for some reason or other, women tend to fall much more than men. And the fall leads to serious injuries. The most important one is probably hip fracture and other osteoporotic fractures, and also lead to head injuries. An unintended injury, which could include a fall, is probably 5th or 6th common cause for death in elderly. And it can result in death, as I told you now. More than falling down, most of the elderly people start walking slowly. They start avoiding walking, going for a walk, because they are scared of falling. This leads to decrease in mobility, decondition. They don't walk, they get deconditioned. And they become more and more dependent on others. And this may lead to social isolation and decreased quality of life. So we need to identify patients who have a fear of fall. Mobility, fall and immobility are a continuum. Those guys who probably were walking now, one day you fall down, and after that you may not become mobile to the same extent as you before. So we need to identify somebody before a real fall occurs. And when somebody complains about fear of falling, or somebody has already fallen in the recent past, they may be already in the midst of a functional decline. So they may be already declining. It's essential to identify them and look for risk factors. What are the risk factors? Muscle weakness, age-related sarcopenia is one of the important causes. Higher the age, people after 80 are more likely to fall compared to people who are 60 and 65. People who have fallen down previously are likely to fall down. Polypharmacy, as I told you already, is an important cause for fall down. Look out for sedatives, look out for antidepressants, look out for antihistamines, even paracetamol at a very high dose, Proxivon, tramadol, all these drugs, even cardiac drugs, can cause significant increase in risk of fall. Some of the drugs which we give for tinnitus, drugs like Verapamil, Cyberium, all these things can slightly cause postural hypotension. Vision and hearing deficits, impaired cognition. This is again important. People who have slight difficulty in judgment, who might find themselves in an odd place without them realizing. They may not know when to place the step when they are stepping down the stairs. So it increases the risk of falling down. People who are already using assistive devices probably already are compromised. Having said that, almost all the falls are multifactorial. Most of the patients who have difficulty in walking have multiple factors including the primary factor. So we need to eliminate or decrease as many risk factors as possible to improve their risk of falling. All of us should go through this side. There's a criteria called Bayes criteria or a Bayes list. These are all the drugs are potentially inappropriate for use in elderly. It is there available in the internet. The list of drugs listed here, most were considered inappropriate for usage in elderly. It's a good list to go through it because sometimes when the elderly patients come, we use the same drug which we use for a 40-year-old man. And the risk for serious injury after fall. Most of us fall. Most of the elderly people fall. Who are the likely one to develop a serious injury? Higher age group, female, and the people who have more than 2 chronic diseases. A diabetic with rheumatoid arthritis is more likely to fall compared to a person with diabetes alone. Thin people are more likely to fall. People with very low BMI. Impaired balance and gait, of course. And patients with arthritis, osteoarthritis, people with bilateral osteoarthritis tend to walk with a gait, bilateral lurching gait, which impairs the balance, they're likely to fall down. So, when we have a patient in a clinic, what are the things we should look for? We should look for syncope evaluation as a general practitioner. Look at the gait, look at the mobility. Make sure that they have gone to the ophthalmologist, check their glasses, if required, corrective cataract surgery. Ask them to check the hearing. Recently, we lost a very close family friend who was almost getting deaf. He was walking in the road. Probably could not realize and react in time when the auto struck him and he died in the spot. Cognitive impairment can be looked at. There are a lot of correctable causes for cognitive impairment like cerebral hematoma, Parkinson's and other diseases, metabolic diseases. Polypharmacy has to be looked at and corrected. So they may not realize that there is a chair there. So they might tumble across the chair and fall down. And always think about vitamin deficiency in people, elderly people, because they are not exposed to sun adequately. And if they are vegetarians, they are more likely to be vitamin D deficient. And this can lead to significant muscle weakness and also to osteoporosis, which would increase the risk of fall and also head fracture. These are the 10 S's we should assess. I'm not going to go through structure, we have already discussed, stride, we have discussed. Always think of infection. When an elderly person behaves a little funnily, gets confused, infection can be present, urinary tract infections, lung infections can present with confusion, which can lead to increase of risk of fall. Somebody walks very slowly, they may be already on the path of decline. Always test the strength. Ask them to get up from a chair with a folded hand. If they are able to get up comfortably, that means their lower limb function is very good. Ask them to lift the book overhead. If they are able to do that, their upper limb strength is reasonably good. Observe the postural reflex. Ask them about the surface at home. One of the other places where people fall is pavements, uneven pavement. Bangalore is always had uneven pavements. So people do fall down. Uneven shoes or ill-fitting shoes. These are the 10 S's we should always look at in patients. What are the things which can be done in every clinic? We should assess the cognition using probably a mini-mental scale, even if it is not available. Ask simple questions about whether they are losing their memory, they are forgetful. Simple questions to look for cognitive defects. Look at BP in supine, standing and sitting position in any patient who complains of difficulty in walking and falling down. This is very, very important. Postural hypotension is not uncommon, which is a preventable cause. A proper advice about how to get up, not to immediately start walking after getting up, waiting for a few minutes in the bedside, even if the bell is ringing, even if the phone is ringing, don't be in a hurry to go, wait for a few minutes and go. And using stockings, liberalizing the use of socks can make a huge difference to postural hypertension. And upper limb strength can be checked. Lower limb strength can be checked by their ability to stand on the tiptoes and the ability to get up from their chair without using any support of the hand. Check the balance using the tandem walking. Ask them to walk tandem. If they are able to do that, they have a fairly good balance. Ask them to stand on one leg. If they are able to do that, they have good balance. And please remember, when you are performing this test, you get up from your chair. Be near the patient. Otherwise, they might fall in the consultation room and they might break a bone. And check the gait. There's a very useful test called get up and go test, which I had described in the booklet which is with you now. Ask them to get up from their chair without support, using the support of the hand. Ask them to walk 10 feet and come back and sit. If they are able to do it within 10 to 20 seconds, their risk of falling down is very low. If they take more than 20 seconds, they are already compromised. They need to be referred to the appropriate clinician depending upon the predominant symptoms. They need balance training, they need exercise training. And every visit, look at the drug list. Because elderly patients go to all the possible specialists. So every specialist gives a list of drugs. Sometimes there is no single family physician who will look at all the drugs and eliminate the unwanted drugs. So somebody has to take the responsibility of fine-tuning the drugs. You notice that some people will be taking 2 NSAIDs, 2 antihistamines, 1 ranitidine, 1 PPI. There are so many drugs. So somebody has to review the medications. So all these measures can be done in a simple clinic wherever you are. It's not very difficult, very high-end neurological test or musculoskeletal test. You don't need a gait lab for doing all these things. So always ask for a history of fall or history of fear of falling whenever you see an elderly person. Particularly if you are seeing them once in a while, always ask this question. Look out for preventable causes like cataract, postural hypotension, and other list of diseases which we are talking about, including vitamin D deficiency. Try to modify these factors and remember that the cause is always multifactorial, so the interventions have to be multifactorial. Appropriate treatment of osteoarthritis, rheumatoid arthritis, dermatomyositis, and all the other treatable diseases, including anemia and diabetes, adequately would prevent some of the walking difficulties and risk of fall. Do drug review periodically. Try to modify the environment which they live. Give the simple instructions like to leave the light lamp on in their bedroom could make a long way in preventing a fall in the bedroom or a bathroom. Preventing slippery bathroom. Most of the bathrooms have the corners are very slippery because water always stagnates and people would tend to fall down. Using a supportive rails, non-slippery mats and putting the lines on, not to change the interior decoration of the house frequently without informing the old man or old lady, and taking care of children's toys. Because when they have grandchildren, the house is full of balls, toys, aeroplanes. If an elderly gentleman steps on an aeroplane, this may be an one-way ticket to heaven. So these are the simple instructions we can give to the patients when they come to our clinic. So a fall can be costly. The prevention is the key. And the approach is always rehabilitation and multifactorial. As a physician, we can correct whatever which could be corrected, then promptly send them to rehabilitation specialists for balance training, footwear modification, assistive devices, and strengthening and conditioning exercises. Thank you very much for your patience.